Hello, everybody. It is 10 o'clock for me and 8 o'clock in California, different times around the world where people are attending, but it is time for us to begin. So, Assalamu alaikum, everyone. Good morning to everyone in North America. Good evening to everyone in Pakistan. I want to welcome you to the Clinical Case Conference today. The topic, as you see, is cardiovascular genetics. And we have a really interesting and comprehensive presentation in store for you. This case series webinar has been brought to you by the Pakistani Society of Medical Genetics in association with APCNA, the Association of Pakistani Descent Cardiologists of North America. So with that, I'm going to go ahead and get started. Okay. So just a few housekeeping rules. The audience will be muted at all times. If you have a question, then please write it down in the chat. And I will be noting all of the questions as they come in. And at the end of our presenters, when they're done presenting, I won't miss your question. I will read it out to them and they will hopefully respond to your questions. So we're going to do that towards the end. If there's a question that comes up in a chat, that one of the presenters feels that they can address in the moment or after their part of the presentation, then they might be doing that. Otherwise, we will get to the questions in the end and have a nice discussion towards the end of the presentation. Also in the chat, I will be posting a link for a Google form. This is just a short survey that we like our attendees to fill. It gives us an idea of who is attending, and it also gives us an idea of what types of topics you would like to hear in the future. So please do just take a minute. It'll just take you maybe a minute or 2 minutes to fill out that form, and I'll post the link at several times during the presentation so you won't miss it, and that'll be in the chat. So with that, I'm going to move on to the introductions. I'll introduce myself first. So my name is Mahwash. I am a genetic counselor. I work at the McGovern Medical School at the University of Texas Health Science Center in Houston. I received my master's degree in human genetics and genetic counseling from Stanford University. And I provide genetic counseling services in several pediatric and adult clinics at McGovern Medical School. I am also the co-founder and co-director of the Pakistani Society of Medical Genetics. And I'm also involved in education and have a role in teaching both medical school students and master's students at McGovern. Okay, next, we're really excited to have Dr. Mahwash Kassi. She graduated from Aga Khan in 2010. Aga Khan is a medical school in Karachi. And then she completed her internal medicine residency and cardiology fellowship from Houston Methodist Hospital. She also did an advanced heart failure transplant cardiology fellowship at the Mayo Clinic in Rochester, New York. Currently, she is an assistant professor at Houston Methodist. She is the chair of the heart failure and transplant section in the Texas chapter of American College of Cardiology. She is also an executive committee member of the Association of Pakistani Descent Cardiologists of North America, APCNA. So thank you so much, Dr. Kassi, for being here and sharing your expertise in cardiology and cardiogenetics with the audience today. Next, I'm also very excited to introduce Monisha Sebastin, who is a genetic counselor. She received her bachelor in engineering from India and her master's in genetic counseling from Sarah Lawrence College in New York. She is certified by the American Board of Genetic Counselors and is a senior genetic counselor at the Children's Hospital at Montefiore in New York, where she specializes in pediatric genetics, cardiovascular genetics, immunogenetics, and in research. She co-chairs the Pediatric and Clinical SIG and the U.S. International GC Subcommittee for the International SIG at NSGC, and she is open to student contact. Interesting fact, Monisha recently won the Heart of Genetic Counseling Award, which is a prestigious award that is through the National Society of Genetic Counselors. So congratulations, Monisha. And next, of course, we have Aisha Furqan. Aisha received her master's in genetic counseling from the Stanislaus State University in California and is certified by the American Board of Genetic Counselors. Aisha works as a lab genetic counselor at Natera in the oncology department and has over 5 years of experience working in rural oncology clinics. She is also co-founder and co-director of the Pakistani Society of Medical Genetics and really is the driving force behind a lot of these webinars that we have. That is the introduction. I am not a presenter, just a moderator, but our presenters today the panelists have declared no conflicts of interest except for their employers, and I've already mentioned those to you. So before we begin with the actual presentation, I just have a couple of slides that go over what the Pakistani Society of Medical Genetics does. And this is for any new members that we have today who don't know this information regarding our society. So we got together in 2020, so we're about 2 years old, but we've achieved a lot in the past 2 years. Our mission is to enable the provision of affordable medical genetic services to the people of Pakistan and to create awareness of genetic disorders through education, community outreach, and research. The founding members, Aisha, myself, Dr. Ijaz Ahmed, who's a geneticist, and Dr. Rizwan Naeem, who's very well known. And all of us have been working on several different causes. We can kind of summarize them in these 4 main headings. So clinical services. So the geneticists here and genetic counselors in the US have been working together to provide clinical services through telemedicine in Pakistan. And the next slide will show you exactly where. And then laboratory services, really the goal is to make genetic testing more available in Pakistan. And so far, we're trying to establish good relationships between international genetic testing companies and those in clinics and providers in Pakistan, so they're able to use those, but that isn't necessarily affordable. So really the goal is to try to get something in Pakistan, so genetic testing done locally, and we're working towards those goals. And then, of course, genetic education, we're also working towards trying to have some sort of certificate program or master's training program based out of Pakistan for education in genetics, such as genetic counseling. So that is in the works as well. And then community outreach, so increasing awareness of genetic disorders in Pakistan through just reaching out to the community. And we do that in different ways. And the webinar today, again, both covers the genetics education and community outreach components of our mission. So hopefully you will learn something and then spread the word. And then this slide just shows us where the telemedicine clinics are happening. So in Lahore, there's a pediatrics clinic at the Children's Hospital in Lahore. And in Karachi, there's a pediatrics clinic at the National Institute of Child Health. And there's a prenatal clinic that they do through telemedicine at South City Hospital. And then, join us, reach out to us. We'd love to hear from you, share your thoughts and questions. Of course, fill out the Google form that I will be putting the link for in the chat, but also you can follow us on Instagram at GC in Pakistan. You can visit our website, that is www.psmg.org, and you can email us, that's our email address, gcinpakistan@gmail.com. And again, that's just a reminder to fill out the little survey. And with that, I will turn it over to Dr. Kassi.
Can you see my slides?
We can see your slides, but we can also see your notes. So yeah, perfect. No, that's good.
All right. So good morning, everyone. My name is Mahwash. I'm a transplant cardiologist at Houston Methodist, and it's my pleasure to be part of this lecture series. And I'm really grateful to our Genomics Society to invite me. Moving on. So basically, I'm just going to go over the timeline for from the time the DNA was first discovered, which is 1953, which is not too long ago, actually, if you think about it in the grand scheme of things. And then the development of DNA sequencing techniques occurred in 1977. And thereafter, the first human genome project was initiated in 1990. And then next-gen sequencing, which really changed the way how fast sequencing can be done, was developed in only 2005. And then finally, at least in the United States, the approval for next generation sequencing for clinical diagnostic purposes was approved by the FDA in 2015. So if you think about it, between 2015 and 2022, the field—
Dr. Kassi, sorry to interrupt, but we can hear you, but your voice is a little bit soft. So if you could either speak up or just move closer. Thank you so much.
Is it better now?
Yes, it's better. Thank you.
All right. So basically, if you think about it, the field of genetics is rather new, and particularly cardiogenetics is, has evolved perhaps over the last 10 to 15 years. And there's a lot that we don't know about cardiovascular genetics and are learning as we go through our patients. So in this particular lecture, we're going to go over genetic basis of cardiovascular diseases. So cardiovascular diseases can be classified as generalopathies, cardiomyopathies, lipid disorders, congenital heart disease, and coronary artery disease. And some of these diseases fall into a monogenic category, which means that a single gene variant causes the disease process. And these are usually generalopathies. They can be cardiomyopathies, and then familial hypercholesterolemia, which is what is going to be the focus of this particular lecture. And then there are polygenic diseases, which are coronary artery disease and atrial fibrillation, which have many genes association along with the environmental factors that lead to those particular manifestations. I mean, coronary artery disease is a very good example of this. But as I mentioned earlier, we're not going to focus on that, and we're going to leave our talk to monogenic diseases. So I've gone over the differences between monogenic and oligogenic diseases. We're going to talk a little bit about sequencing techniques, but we will talk more about tests and how to do the interpretations for these tests, what are possible pitfalls, and then this will be a case-based discussion so you can learn from examples of how we utilize genetic testing in each of these clinical scenarios. What we're not anticipating at the end of this lecture is to allow you or ask you to do genetic testing, because that's something that comes with certain nuances, and we'll definitely give you resources to understand how to order those and then interpret them, but it is certainly not something I anticipate that you'll learn out of this particular lecture. So why is it important or relevant to do genetic testing is because, as I mentioned earlier, monogenic origin of disease occurs in the pediatric and young adult population, particularly in association with heart failure and sudden infant death syndrome. 40% of sudden cardiac death in young individuals are attributed to generalopathies. And in idiopathic dilated cardiomyopathy in adults, the proportion of familial disease is found in family screening and as high as 30%. And I think this is still an understatement. There may be more. And even when you take into account or adjust for myocardial infarction, diabetes, and hypertension, there was a Framingham offspring cohort study that was done that if you had a family member that had heart failure at the age of less than 75, you still could have a pretty significant risk regardless of the other or adjusting for other clinical risk factors. And the prevalence of familial hypercholesterolemia, which is also going to be an important part of our discussion today, is around 1 to 220 and can cause premature coronary artery disease and result in death in a lot of our patients. Now, as we know that Pakistan is the second largest country in South Asia and the sixth largest in the world, 193 million population, faces serious healthcare issues, which predominantly are cardiovascular in origin. This was an interesting study that was done in Pakistan, which they looked at mutational load for cardiovascular diseases. And the highest number of deleterious variants contributing to common cardiovascular disease were linked with, of course, hypertension, atherosclerosis being at the forefront, but also with heart failure, with other cardiomyopathies, with cardiac arrhythmias, and then congenital heart disease. And a lot of times young people die of cardiomyopathy, sudden cardiac death, and we just assume that, they just had a sudden heart attack. That's the word that is commonly used. And no further investigation is done or looked into why these young people died. So this is the breakdown from that particular study where they looked at the different mutational loads. Now, switching gears to heart failure. Now, heart failure is a complex and it is a diverse disease phenotype, meaning how it presents itself, and it has variable heritability. Um, and in the field of heart failure, monogenic heart failure syndromes caused largely by a single gene mutation is a complex trait in itself. And we know that based on clinical and genetic evidence that most of these cardiomyopathies are inherited. And in the last 20 years, the systematic approach that we've taken to family screening has contributed to a better assessment of familial cardiomyopathies. The genetic investigation of dilated cardiomyopathy is sparse. However, I'm going to say that it's not like there's no interest. This was a very interesting study that was published in Gene in 2018, which the authors, Dr. Khan and Shakil, looked at rare genetic mutations in Pakistani patients with dilated cardiomyopathies. And there were certain variants that were identified that are linked to Pakistani population in particular, and more work needs to be done in this realm. I did also do a literature review from Pakistan looking at what are the cardiomyopathies that are reported, and they can be anywhere from things like associated with beta thalassemia major or dengue fever. But there are definitely genetic mutations that have been reported, or variants that have been reported, like limb girdle muscular dystrophy or hypertrophic cardiomyopathy, ARVC, and then amyloid. So it's not like the Pakistani population doesn't have inherited cardiomyopathies or inherited reasons for heart failure. It's just that they're under-recognized. Now, moving to why do we pursue genetic testing if you look at the big picture, why is it relevant? Usually when we do any kind of test in the field of medicine, that needs to be medically actionable for us to determine its relevance. So if we take this upon genetic testing, it can be used for diagnostic purposes. It allows us to prognosticate patients. It allows us to do therapeutic strategies, especially we're living in an era where you may have heard of CRISPR-Cas9 technology or gene editing, where basically if there is a gene that is a mutant or a variant gene that can be eliminated from that particular individual using gene editing techniques, which of course are not still at the forefront and they're under clinical investigation, but that certainly opens up a realm for therapeutic use of genetic testing. And then it allows us to do cascade screening, which is perhaps the most important part in talking about familial heart failure or cardiomyopathies, because that allows us to determine the risk of individuals that are linked to that particular patient that has the cardiomyopathy. If we look at the overall breakdown of some of the more common cardiomyopathies, such as dilated cardiomyopathy or ARVD or hypertrophic cardiomyopathy, there are certain cardiomyopathies where we definitely know that there is a role for diagnostic purposes, such as in hypertrophic cardiomyopathy, but not so much in dilated cardiomyopathy. We may or may not use it for that purpose, but of course, what I'm trying to say here is that there is a very important role for first knowing your patient, knowing their clinical history, knowing their imaging. So basically, you have to really understand their phenotype. You can't just start with a genetic test. You have to start by knowing your patient's history, a detailed physical examination, EKG, echo, and then MRI. I'm going to go straight to MRI because that is what we eventually use to define the phenotype. And in the European Society and the Heart Failure Society of America have basically agreed to 4 different phenotypes, which is dilated cardiomyopathy, where if you look at this image, this is an inverted heart image. The left atrium is at the bottom, the ventricle is at the top. The heart almost looks like a basketball. That's typical for dilated cardiomyopathy. The heart is big. It doesn't function well. It doesn't eject blood enough. So ejection fraction, which is a functional characteristic of the left ventricle, is reduced. This is restrictive cardiomyopathy, where basically the heart becomes thick. As you notice, the walls in this image are much thicker than the walls in this image, and the heart cavity becomes smaller. Then there is hypertrophic cardiomyopathy, which can be kind of co-associated with restrictive cardiomyopathy, but is an entity of its own based on the amount of research and genetic testing that is being done in hypertrophic cardiomyopathy. And so basically, this is an entity where the heart muscle becomes asymmetrically thick, as can be seen in this particular image, where the septal wall, this is the septal wall, which should not be more than 1.2 centimeter, is around 3 centimeters here. And it is usually without association of hypertension and has strong genetic predilection and association with sudden cardiac death. And then there is arrhythmogenic right ventricular cardiomyopathy, which also has typical imaging characteristics, including aneurysmal right ventricle, RV dysfunction, RV hypokinesia, and there are different other features that are by EKG, such as epsilon waves that basically help us make the diagnosis. But importantly, now genetic testing is one other important component of making diagnosis with arrhythmogenic right ventricular dysplasia. There is one category which is known as LV non-compaction, where basically your heart goes back into its original embryonic kind of phase where the heart becomes trabeculated and it's non-compacted. This type of cardiomyopathy, there is some controversy, and there are one group of people that think that this is an individual entity and this should be a separate cardiomyopathy and it's genetic. But there is another group of individuals who definitely believe that this is just a phenotype and it can be associated with various different cardiomyopathies. So it's not safe to call it a separate cardiomyopathy. We also know that there are certain physiological conditions that can cause non-compaction, including athletes and pregnancy, and other features like or diseases such as sickle cell disease can cause LV non-compaction. But you have to really then understand the patient in terms of their past medical history, who they are, how much do they exercise, and if they are pregnant or not. So why not do genetic testing for everybody, or why not just begin with genetic testing? Again, it comes down to the same point. If you don't have a good phenotype and you do genetic testing, um, inappropriate genetic testing, you may end up with misinterpretation of results. For example, in this group today, if we did genetic testing of all the people that are present here today without a known heart condition, they may be carriers of certain variants, which may not manifest ever, because there are certain concepts in genetics. One is that there could be a variable expressivity, which means that not everyone who carries a certain gene will express the gene in that kind of way. For example, you may be carrying a variant for dilated cardiomyopathy, but you may never develop dilated cardiomyopathy. And there are certain variants that are present in populations in general, like such as long QT syndrome. So it is inappropriate to do genetic testing in everybody and without appropriately phenotyping them. So it is a tool that you use in conjunction with everything else that you have available. One other important, just from a wording perspective, that we usually don't use the word mutation in our field anymore, because it connotates a negative. It has negative connotations. So we use the word variant instead of mutation, and I'll stick with that for the rest of the presentation. So this brings us to the point that genetic testing results are only probabilistic and not deterministic. Again, this slide is not just, it's not an error, it's where I'm trying to emphasize that define the phenotype first, know your patient first, and then order the genetic test. And so when you order the genetic test, of course, do genetic testing where it's indicated, and what type of genetic tests are available. So there could be single gene tests that can be ordered. Usually in our field, in heart failure, we use a panel, which means that it is a panel that is for known variants that are associated with cardiomyopathies. And that panel is extensive, but it only includes maybe around 30 to 40 known variants. But if the particular for example, a patient has a negative test, that may be just because the panel did not include that particular variant. And if that is the case, and you're strongly suspecting a genetic reason for the disease, then you could order exome or genome sequencing, which is more extensive and a little bit more expensive. But I know that there may be people in the audience that are particularly in Pakistan, we don't have genetic testing or these type of panel testing readily available. But this slide was contributed by Aisha, one of our genetic counselors, who's going to be talking about familial hypercholesterolemia. And this is a free resource available to everybody, which is from the National Library of Medicine. You can basically use this genetic testing registry and enter your disease phenotype. For example, in this case is an example of familial hypercholesterolemia. And this will tell you how many tests are available and which labs have those tests available. So for example, you can enter your country's name or the nearest country to you, and can maybe ask for a lab through that particular, ask for a panel or a genetic test through that lab. The lab may be able to send you that genetic test, and you can just draw blood or give a buccal mucosa sample and send it to that particular lab. So all hope is not lost if you don't have genetic testing readily available in Pakistan. There are these resources that can definitely be used. Now, when we get the genetic test result, varies from benign to pathogenic. This is a very good representation of the 5-point scale that indicates the likelihood that a particular variant is associated with disease. So as I mentioned earlier, that since the field of genetics is rather new, so there may be variants that we are still uncertain about. And so they're called variants of unknown significance. However, just to give us a little bit more hint about whether we should be thinking about these variants or a little bit more deeply, they may be classified as likely pathogenic and likely benign. And if you have then, pathogenic or benign, those are the extremes. We will go over some cases to explain how to interpret and look at these test results best. So this is a case of a young gentleman that was referred to me. Basically, was found to have LV non-compaction phenotype that was found on surveillance testing. The surveillance testing was performed, or an MRI was performed, because the patient had a father who had heart failure, and then a son who had basically died as sudden infant death syndrome. This is again his MRI, and as can be seen here, this is the left atrium, the right atrium, and this is his left ventricle. The ejection fraction seems reduced, and then they can see that there is prominent trabeculations in both the left and the right ventricle. Now, when we further asked history, apparently it turns out that his father also was a patient in our system, and he was being seen by adult congenital heart service. And he basically had Epstein anomaly and non-compaction. And his son, of course, had died with sudden infant death syndrome. He had 2 other sons that were unaffected. Interestingly enough, there was an autopsy that was performed for the son. I was able to contact the pediatrician who was seeing the patient at the point of his death, and the pathologist who had performed the autopsy. And it turns out that they didn't find any suggestion of non-compaction, but his ventricle appeared thick. And then, of course, he did not know the details of a lot of his other family members, but he mentioned that he had 4 other sisters who basically had, his father had 4 other sisters who basically had variable heart issues, ranging from congenital heart disease to arrhythmias. This is, of course, not to stereotype a typical man who doesn't know a lot of details about his family, and I'll explain why. So what do we do next? So basically what we did was we first took the genetic test result from his father, who had the Epstein and non-compaction, and we found that he had 2 variants. One was PTPN11 and MYH7 was the second one, and both of these were variants of unknown significance. Now, the PTPN is usually associated with Noonan syndrome, and they have typical facies, and there was no suggestion that the father basically had those facies. As I mentioned, he was seen by adult congenital service, and they're very good about understanding who has the typical facies for Noonan syndrome. But then he had this other gene which is associated with basically cardiomyopathies. This is a typical result that you get. The genetic test results services usually give you an explanation of what the gene is, what is it associated with, what are features characteristic of it. So it's very helpful, and they also quote literature, which is very helpful for clinicians like me. I have not had any formal training in genetics, and I rely heavily, of course, on our genetic counselors, and then, of course, how the testing is done, and do more literature search. So this gene was basically associated with autosomal dominant cardiomyopathies and even hypertrophic cardiomyopathy. But we thought about it, and we wanted to know whether this variant is associated with what we are seeing in the sun. So the next step was to study the patient, or in the world of genetics, the proband who has the disease. And in him, again, we noticed that he had the MYH7 partial deletion, but not the PTPN. So then we did further, of course, testing, and it kind of felt that this may be of relevance, and recommended cascade testing or familial testing for all the family members that were involved. 2 years later, I had another patient who basically presented because she had an atrial aneurysm, and she mentioned that she had a pretty extensive family that had all the cardiomyopathies. And turns out they had different last names, but this was one of the aunts that we had talked about earlier, and she was able to give us a lot more detail. So there was tetralogy of Fallot, there was another sister who had LV and C, there was one unaffected sister, And then the one who had tetralogy of Fallot had a son who had a PFO. The one with LVNC had the most impressive family, where they had Epstein anomaly and pulmonary atresia in one of the kids who had deceased. Another daughter who had LVNC, who basically who actually didn't have genetic testing, but a son who had LVNC, and then another son who had LVNC. So we then performed genetic testing in one of the relatives who basically had non-compaction, and they also carried the same genetic variant, which was MYH7. So with this, we concluded that this is of relevance, and we reported this to a database, which is this is again a free resource where you can put in either a gene or a particular condition, and the gene variant that we got for our patient. We put this in, we did a literature search, and with the help of our genetic counselors, we were able to report this variant of so-called unknown significance to the database, and turns out that they were able to change the classification of this particular variant to a variant of likely pathogenic in origin. So while usually variants of unknown significance are some things we don't hang our hats on, and usually we tend to classify them as benign and until further evidence is collected. But in a family that has this type of presentation where it's so extensive, it is very important to not lose sight of these, and don't just disregard the result. You have to investigate further if it is such an extensive history in the patient and in the family. So again, ClinVar is the free database. I cannot go over how to use ClinVar. It's not as user friendly, but we can definitely do a separate session if people were interested in learning about how to put in data in ClinVar and how to do search. So just a little bit about LVNC. Again, it's a cardiomyopathy where there are prominent trabeculae and recesses, and then the normal thin compacted layer is changed for a non-compacted area. And there it shares genetic mutations. There's one that is the M1B1 that was segregated in an autosomal dominant fashion in a Spanish family, and a mouse model was also implicated. And there are other signaling pathways that can be implicated in this cardiomyopathy, which is why I'm of the group that believes that LVNC is a separate cardiomyopathy. It is class 1 recommendation according in the US to do a mutation-specific genetic testing for family members and appropriate relatives following the identification of an LVNC causative mutation in the index case. And it's a class 2A, it can be helpful for patients whom a cardiologist has developed the diagnosis of LVNC based on examination of the patient's clinical history, family history, and ECG, and echocardiographic features, which is what we did in this situation. So should I believe what I see if you see a negative test result? So of course, as we know that there, as I mentioned earlier, it can be a panel, and the panel can miss that particular gene, or it could be a gene that we have never studied before. So it's very important to just not disregard the test result if the test result is negative, and if there is family history and you do a 3-generation family history and there is other family members that are affected, it's very important to still do familial screening using echo, ECG, physical examination, and don't just disregard a negative test result. A negative doesn't always mean negative. And with this, I want to show this table, which shows that the estimates of genetic testing diagnostic yield in different cardiomyopathies. And as you can see here, the diagnostic yield is highest again in hypertrophic cardiomyopathy, that is the most well-studied cardiomyopathy, and it is lower in other, but it's growing. So this number may grow in a couple of years, but this is important to understand that a negative test result doesn't always mean negative. And of course, the diagnostic yield of genetic test is less than 100%. And it should not be used to rule out a genetic cause. Now, if you have a pathogenic variant, again, you have to really understand, does it match the phenotype? So it's very important to, if you have a genetic test result in hand and it is a pathogenic variant, may not correlate with phenotype, then it is again a problem, because you cannot have a gene that causes long QT syndrome and you try to explain that with somebody who has perhaps LV and C. So the two are not related, and it's very important to look at what you're dealing with and match the two. And then, for instance, again, we went over the case for variant of unknown significance. And again, you have to ask yourself the same question that we asked ourselves: does it match our phenotype, and how does it go in the family? Is it affecting everybody that is that has the disease? And in our case, it was the case. That was the case. So the field of genetic cardiomyopathy is relatively new, and there is definitely a lot we don't know, and a lot of what we know may be wrong. So there was a paper that where variant of unknown significance were reclassified to mostly benign or pathogenic, depending on more information that came through. So it's very important to understand that we're still learning and still evolving. Now, this is another case, which is a smaller case. It's a 50-year-old patient who presented for evaluation of chest pain and shortness of breath. His notable past medical history was that he had a debilitating stroke, leaving him aphasic and hemiplegic. And interestingly enough, his brother had heart and liver transplantation. So the referring internist, and he was subsequently also seen by our congenital heart disease team, thought that maybe most likely the brother had amyloid. The assumption was based on the fact that usually we do heart and liver transplantation for amyloidosis, which is abnormal protein producing kind of a condition which involves the heart, and the production is in the liver. So that's why the heart and liver are both transplanted. So this is his EKG. Usually in amyloid, we see low voltage and a septal infarct pattern. But in this one, to the contrary, the patient had left ventricular hypertrophy and deep T wave inversions, which is usually doesn't go along with amyloid. This is the echo that was already performed, and the patient, again, this is a 4-chamber view. The atria are at the bottom, the ventricles are at the top. The ventricle looks very hypertrophied. And if this is another view, again, the septum looks very thick. This is, if you can remember the earlier phenotypes that I showed you, this is showing that the septum is again thick. So what I did in this situation, I just went back to the patient's brother's explanted heart. And what this basically showed was that the patient's heart had what we call severe hypertrophy, and also myocyte disarray, which is consistent with hypertrophic cardiomyopathy. And the sections of the heart showed cardiac muscle with a haphazard bundle of myocytes with enlarged angulated nuclei. This is not from the patient, but a representative image, and you can see that in. Sorry, can everyone mute? So that showed myocyte hypertrophy, myocyte disarray, and then interstitial fibrosis and endocardial fibrosis, which is suggestive of hypertrophic cardiomyopathy. And in this situation, we then did a genetic test, and the genetic.
Dr. Kassi, I'm sorry to interrupt you, but since you're the host, you will have to mute the person who hasn't muted himself. It's Mohammed Sarfraz.
Okay. I actually can't figure out. Oh, that's it.
Go under participants.
Okay, I did. Okay, sounds good.
Thank you.
So this is the genetic test result from the patient, and this was a pathogenic variant which was identified in MYBPC3, which is associated with autosomal dominant hypertrophic cardiomyopathy. And basically, this helped us nail the diagnosis. Unfortunately for the patient's family, there had several family members that had died in sudden cardiac death, and largely the family was ignorant of the fact that of course one patient had had a transplant. There was another aunt who had been evaluated for transplant but was not transplanted. There were several young family members that had died, and so if we had made this diagnosis earlier, this would have saved a lot of their family members, number one. Number two, this patient who suffered a stroke, usually hypertrophic cardiomyopathy is associated with stroke. And a lot of these patients can, if they develop atrial fibrillation, have to be anticoagulated with warfarin. And we need to make sure that they, number one, we appropriately risk assess them for sudden cardiac death. Number two, we put them appropriate anticoagulation if they need, because it can cause a devastating stroke in these patients. And this is our patient is an example of that. So just a little bit about hypertrophic cardiomyopathy. It's considered to be a disease of sarcomere and variations in genes encoding sarcomeric protein, in which there is a low tolerance for genetic variation. One other important thing I want to mention is that we now kind of think about hypertrophic cardiomyopathy in sarcomeric and non-sarcomeric, and there are certainly a group of hypertrophic cardiomyopathy patients who do not have a positive genetic test. And we think this could be because either we're just not detecting the right genes at this point in time. So that's certainly something that's under investigation. And a lot of people are still trying to figure out why we do see hypertrophic cardiomyopathy but not a genetic test result that's positive. It is a common disorder, believe it or not. It affects 1 in 500 people in the United States, and it is characterized by unexplained cardiac hypertrophy, myocyte dysuria, and fibrosis. Even though the typical teaching is that you should have to rule out that they don't have hypertension, and hypertension is not causing the hypertrophic cardiomyopathy, but the non-sarcomeric type of hypertrophic cardiomyopathy is actually associated with hypertension and obesity. So that is actually an interesting development in the recent years. And there can be, it says autodominant, and you could be a gene carrier, but doesn't mean that you would develop the disease. So it's very important that if a person tests positive for that gene, if there's a family member that's positive for the gene, they're appropriately counseled that not everyone is going to develop the respective disease because because of this phenomena, which is the phenotypic variability, which is what I counsel my patients about. And penetrance increases with age, meaning that maybe more manifestation later in life, but remains incomplete in a lot of patients. And phenotype guided genetic testing and echo can be used to basically dictate which one, if you have hypertrophy or not. Then there is this important to understand that hypertrophic cardiomyopathy can mimic other diseases such as Fabry's, amyloidosis, Danon's, and Friedreich's ataxia. One thing I want to mention about the panel testing in the United States is it's foolproof because the panel includes all these other diseases as well. So we've had certainly patients who were sent to us for hypertrophic cardiomyopathy. They look like hypertrophic cardiomyopathy in MRI, but turns out that they tested positive for Fabry's, so or amyloid. So it certainly is that needs to be ruled out and and appropriately screened. And then we use different screening tools to identify patients who are at risk. Usually, if you are genotype positive, doesn't necessarily mean you need a defibrillator automatically. You have to meet other criteria. And these are some of the clinical risk factors for sudden death and hypertrophic cardiomyopathy, which includes VF, prior history of cardiopulmonary arrest, spontaneous sustained ventricular tachycardia, a family history of sudden death. Syncope is a big one. Non-sustained VT on some kind of monitor, abnormal blood pressure response to exercise, and massive left ventricular hypertrophy that is greater than 30 millimeters. So there's actually kind of like an app available, and that is, and there's some in development that can be used to stratify risk for sudden cardiac death. So the recommendation, class 1 recommendation for hypertrophic cardiomyopathy is comprehensive or targeted. Genetic testing is recommended for any patient in whom a cardiologist has established a diagnosis of HCM based on, of course, physical exam and ECG and echo. And mutation-specific genetic testing is recommended for family members and appropriate relatives following the identification of the causative variant. This is just I don't have time to go over all the clinical care of patients with hypertrophic cardiomyopathy, but certainly the various nuances of that are familial screening, symptom alleviation with, of course, lifestyle modifications, and then there are medications, beta blockers, calcium channel blockers that are used in patients who have obstructive, which means that the ventricle is thick enough to cause obstruction of the flow. And in those, we use beta blockers and calcium channel blockers. And then there's definitely surgical or transcatheter approaches available to reduce the septal thickness. And then, of course, the sudden cardiac death risk stratification, which is a shared decision-making between the patient, the family, the cardiologist, the electrophysiologist, and of course, an important portion of that, again, is genetic counseling. Patients who are high risk should undergo, of course, ICD placement. This is just a cartoon to show the MYH7 and MYBPC3 encoding heavy chain and myosin binding protein C that are the two most common genes involved, accounting for about 50% of hypertrophic cardiomyopathy patients. My last point is that, of course, I know that, ICD and pacemakers are a limited resource in Pakistan, and, there can be, it's very, very heavy on the pocket. So APCNA has this project that is for pacemaker, and that certainly, includes defibrillators in patients who are at risk, particularly the young patients who are at risk. So if you or your family member or your patient are in need of a pacemaker or defibrillator, this resource can be used and is available in several hospitals, and we can give you more information about that, or you can visit the website to understand where the projects are ongoing. So with that, I'm going to stop. This is my Twitter handle. If you have any questions, you can reach out to me through Twitter as well, or we can answer at the end of this session. I'm going to stop here.
Thank you, Dr. Kassi, for that amazing presentation. I think everyone, it was very informative, and I'm for sure learned some new information, so I'm sure everyone else did as well.
I have made Monisha.
Monisha host, okay. So Monisha, whenever you're ready, you can share your slides and begin your part of the presentation.
Okay, can everyone see my screen?
Yes, we can.
Yeah. Okay. I want to thank PSMG for giving me this opportunity. And now we're going to talk about two arrhythmia conditions in my presentation. So the first condition we're going to talk about is a patient who was referred to our clinic, a 40-year-old male with multiple syncopes and one EKG pattern suggestive of Brugada. In the past, this individual was positive for an EEG negative seizure, and his seizures are controlled by medication. And he was referred to our clinic because of a recent hospitalization due to chest pain, which turned out to be due to a spontaneous pneumothorax. And with respect to family history, we did not have much information because the individual was adopted out. And the cardiologist who referred the patient to the clinic wanted to know if an ICD is indicated for this individual or not. So an ICD is an implantable cardioverter defibrillator. You can think of it as a device that gives PCR internally when the heart beats abnormally. So in this patient's case, they are asymptomatic when, with respect to what you would expect when someone has Brugada syndrome, and they've had one EKG suggestive of Brugada pattern. And it's important that we take into consideration their seizure history, and if the seizures were actually arrhythmias that were presenting as seizures, then an ICD or the best therapy treatment or management for Brugada would be approached aggressively. Although genotyping alone should not dictate the decision to manage an individual, this information can definitely provide more guidance as to how we should be going about with their care. And also knowing the underlying genetic cause can help the other family members, similar to what we saw in Dr. Mahwash Kassi's presentation. So it is very important that we identify the right test to order for the right person at the right time. And we could go as there are multiple panels available when it comes to genetic testing and for cardiac conditions. And when we say the right person, we are referring to the results are more meaningful when you test the person who is symptomatic. Genetic tests come in many shapes and sizes, and these are some of the factors that go into consideration when we are deciding what test to choose. And of course, there are certain aspects that are very unique to what's available in the US. So in the case of the patient, we were taking all the factors into consideration, we decided to go very targeted in our testing, and we ordered the Brugada panel test, which looked at 20 genes and that are associated with Brugada syndrome and other arrhythmias that can present with features similar to Brugada. And not so surprisingly, the individual came back negative, meaning they did not identify an underlying genetic cause that explains what's going on with them. So during the visit to return the results, the patient laughed when we returned that we did not find an answer. And they said that they were mentally prepared for it because we had discussed that the likelihood of finding an answer is very low. And they raised a very good question of if this was due to their seizures and if they needed an ICD. We emphasize that the results do not necessarily mean that Brugada syndrome is ruled out. The reason we emphasize that is when it comes to Brugada syndrome, as mentioned in the previous presentation, the knowledge of genetics and cardiology is not as advanced as we would like it to be. So the likelihood of finding an answer is very low. It's only about 15 to 25%. So as a result of the low diagnostic yield, we were not able to rule out the condition. So the recommendations for this individual was they have 2 children, a 4-year-old and a 15-month-old. So we recommended that the kids follow up with their pediatric cardiologist because we're not able to rule out Brugada in the person who's presenting with the symptoms. And we also emphasize that this is not urgent because this is a condition that typically presents in the 3rd or 2nd decade of life. And we recommended that if the children start presenting with any symptoms such as seizures, fainting episodes, complaints about their heart beating funny, they should be evaluated sooner. And we also discussed that one of the main triggers for Brugada syndrome is high temperature. So if the children, in the event of a fever, start presenting with any of the symptoms highlighted above, they should be taken to the ER. And once, irrespective of whether a diagnosis is made from a genetic standpoint or not, for anyone who has a cardiac condition, their cardiologists become their best friends. Irrespective of whether we find an underlying genetic cause or not, the management will require them routinely following up with their cardiologist. So let's look about what Brugada syndrome is. The image that I'm showing are the different types of Brugada patterns one can see on an EKG. And the tricky part about Brugada is it does not always present. And some triggers that bring out the pattern on an EKG are medication and high temperature. And so when an individual is diagnosed with Brugada syndrome based on their clinical features or based off of genetic testing, we recommend that we provide them with the information of Brugada drugs, where you have a list of medication that we would recommend that they do not, they stay away from. And Brugada syndrome, the very first symptom can be sudden cardiac death. And one of the common family history information we get is individuals saying, oh, they died in their sleep. They were healthy and they passed away all of a sudden. So those are some family history information that should make you think of Brugada syndrome. And so these individuals, they tend to pass away in sleep or at rest. And it's one of the most common causes of sudden unexplained nocturnal deaths and sudden infantile deaths. And the typical age of onset is in the 40s. And the most common cause, a genetic cause of Brugada syndrome is loss of function variants in the SEN5A gene, which accounts for 15 to 30% of the cases. And the prevalence of Brugada syndrome is 1 in 2,000. And it's most commonly seen in East and Southeast Asian population. And in the Pakistani population accounts or 0.8%. So when it comes to diagnosing someone with Brugada syndrome, if an individual presents with Brugada pattern on EKG plus one of the following features, such as recurrent syncope, ventricular fibrillation, self-terminating polymorphic ventricular tachycardia, cardiac arrest, family history, which is strong for sudden cardiac or sudden unexplained cardiac deaths, family history of young unexplained deaths at sleep or at rest. And in individuals who have a Brugada pattern on EKG, but no symptoms of family history, we should first rule out other phenocopies of Brugada, such as metabolic conditions, myocardial ischemia, and pulmonary embolism. And in these individuals, we do procedure called procainamide challenge, which is basically a drug that will bring out the Brugada pattern. It will act as a trigger, as an external trigger, and this is done in an environment with the EPs. So it is a protected environment. And the differential diagnosis in these individuals should include first-degree AV block, intraventricular conduction delay, right bundle branch block, and sick sinus syndrome. So case 2, this was a 7-year-old male who was referred to the genetics clinic for concerns of autism and intellectual disability. The family had moved to the US a few months before they met with us. So the prenatal and the birth history was insignificant. The medical history was positive for autism, intellectual and developmental delays, syncope, and some cardiac problem, which the family was not sure what it was. And because they had just moved to the US, there was also delays in the transfer of medical records. So the physical examination performed by the geneticist was suggestive of round faces, flat nasal bridge, small teeth, and syndactyly. And the family history, as you can see, is relatively not concerning, except for seizures in the patient's father. So based on the information we have, where this child is presenting with delays and autism, ACMG, which is the American College of Medical Genetics and Genomics, they recommend the first-year testing to be a microarray. And given the fact that this is a male with delays, they also recommend Fragile X syndrome, which is the most leading cause of autism in males. And after obtaining consent for these 2 tests, the test was performed and the patient came back normal, meaning the microarray and the Fragile X were fine. And when we met with the family for the discussion of the results, they managed to get the cardiology records from their country. And the child reportedly presented with abnormal EKGs, where there were 2 encounters of corrected QTC intervals of 470 and 500. So after returning the results and with the new information we had, we told family that we would like to offer further testing, that because the child right now, based on the cardiac history, has been presenting with long QT pattern on EKGs, and the child has other features which are making us suspicious of syndromic long QT. So we consented the family for a test for long QT genes, and we discussed the genes, inheritance, and implications of what these results, potential results could mean for the individual and the family members. And we reviewed long QT syndrome in detail, including the different subtypes. And the test that was sent in the individual came back with a pathogenic variant in CACNA1C gene. So disease-causing changes in this gene are associated with Timothy syndrome, which is an autosomal dominantly inherited multi-system disorder that is characterized by cardiac features, as well as neurodevelopmental features and other systems of the body that are affected, which are listed in the extracardiac phenotype, as you can see. And the cardiac presentations can range from increased QT intervals, AV block with bradycardia, tachycardia, congenital heart defects. And this is inherited in an autosomal dominant manner, as I mentioned earlier. And so now we're going to look into what is long QT syndrome. So long QT syndrome can be diagnosed using an EKG, where the individual can present with longer time than typical what you would see for the repolarization of the ventricles. And this is an image to show the difference between the normal QT interval and the prolonged QT interval. To start the points or morphological abnormalities of the T wave. And long QT can be due to an underlying genetic cause or due to a medication that's provoking long QT syndrome. Typically, when we have children with ADHD, there are some ADHD medications that can trigger long QT. So in our clinic, whenever a child with autism or ADHD is going on certain medication, they refer the child to a cardiologist to make sure that they are clear from a cardiology standpoint. And then electrolyte imbalances, and the prevalence is 1 in 2,500, and it's pan-ethnic. So there is the Schwartz long QT score, which based on the EKG findings, clinical history, and family history, can indicate the probability of someone having long QT syndrome. And a 0.1 is low probability, 1.5 to 3 is intermediate probability, and 3.5 is higher probability of having the syndrome. In addition to other arrhythmias, your differential diagnosis when it comes to long QT should include the use of drugs that could provoke a long QT pattern on EKG, low levels of potassium in the individual, and certain neurological conditions, including subarachnoid bleeds and structural heart defects. So when it comes to long QT, there are 15 types, but the most common 3 are type 1, type 2, and type 3, which are caused by different gene channels, as you can see. And the type 1, the trigger is any sort of strenuous exercise. So when this is a condition that the onset is in childhood, and it accounts for 30 to 35% of long QT. And type 2 is caused by disease-causing changes in the Kassi and H2 gene. And this is triggered by strong emotions and loud noise. So when someone's diagnosed with this condition, we recommend avoiding loud noise, like the alarms, or sharing any information that could emote a strong emotion or reaction. And the onset of this is around puberty, and it accounts for approximately 25 to 40% of the cases. And then type 3 is caused by changes in the sodium channel, SEN5A, and the trigger for this is sleep. And this again starts presenting around puberty and accounts for 10 to 15% of the cases. SEN5A might, you might recall this from the previous condition we spoke about, Brugada syndrome. So the difference in the two is Brugada is caused by loss of function variants, and long QT is caused by gain of function variants in the gene. When it comes to the genetic standpoint, with respect to inheritance, you have the autosomal dominant type of long QTs, which is further classified into the isolated form where you see just long QT and no extracardiac manifestation. And then the second category where you see additional cardiac manifestations like the patient we discussed earlier. And that has two main conditions. One is Anderson-Tawil syndrome, which presents with long QT, dysmorphic facial features, and high or low potassium levels. And Timothy syndrome, which was what we saw in a patient earlier. And then the recessive forms, where you have Jervell-Lang-Nielsen syndrome, which is caused by biallelic variants in the KCNNE1 gene or KCNQ1 gene. In these individuals, you see prolonged QT and hearing loss. So it becomes important when you are collecting the family history to be comprehensive and not just focus on the cardiac features, but also ask about other factors such as neurodevelopment as well as hearing loss. So when it comes to management and treatment of long QT syndrome, routine EKGs and cardiac follow-up is recommended, and cascade testing if we identify an underlying genetic cause. Lifestyle modifications depending on the type of long QT they have, and to avoid medications that can prolong the QT interval, avoid strenuous exercises in the case of type 1, competitive sports, And type 2, we would recommend avoiding loud noise or stressors and loud telephone ringtones. And then address electrolyte imbalances if someone has diarrhea or vomiting. And during pregnancy, especially for individuals with type 2, it's important to know the type of long QT they have, because in the postpartum period, that is an increased risk of cardiac arrest. And medication, they're usually put on beta blockers, and invasive procedures are another management offered to individuals with long QT, such as ICDs, LCSD, if ICD and other treatments are not effective. And in the Credible Meds is the website we offer individuals who have long QT to look up the drugs that they can take or drugs they should be avoiding. Thank you so much for the opportunity. Okay.
Thank you, Monisha. That was a really good presentation. And again, very informative. So next, we have Aisha Furqan, and she is our last presenter for today. And after that, we're going to go into the question answers.
Thank you so much, Myla. Thank you, Dr. Kassi, and thank you, Monisha, again for joining us today. I definitely learned so much, and I am excited to present my part of the presentation. I am just getting started and connecting to my presentation. It might take a minute for it to go into presentation mode. Sorry about that, it's spinning. Everyone can see the slide okay, where it says hypercholesterolemia?
Yes, we can see the slide.
Okay. It's thinking.
I know there was a bit of a lag when I started too, but then once it got started, it was fine.
It was fine, yeah.
Shall we do some questions in?
Oh, that's a great idea. Let's do that. So we had a couple of questions, Dr. Kassi, from your part. The first one was from Noor-Alan, and she was asking, what does poor phenotype mean? Isn't it that if a person is sick with some disease, they have poor phenotype?
Okay, so poor, I guess that's a poor choice of words from my end, but it means poor. What I was trying to say is poor phenotyping, meaning that you didn't do a good exam, you didn't do an ECG, you didn't do a good image like an echo or an MRI, and you did not appropriately put them in a certain category, meaning a certain phenotype. And not knowing all of that, you went ahead and just did a genetic test. So I get many referrals for this, and family members will just come to my clinic and they'll say, I have a family history of XYZ, do my genetic test. And I say, no, that is not how we start. We can screen you, we can do an EKG and an echo, but we're not going to do the genetic testing on you. Rather, we'll get the genetic test result from your family member. A lot of times you'll be surprised, even in the United States, like the cardiologists that are taking care of the patient will not have done genetic testing. Again, like I said, there's no formal education, unfortunately, for us cardiologists to understand these things, and you have to kind of put enough effort and go to courses. And by the way, there are some courses that are available even virtually that if you guys can look up, and there's one through Mayo Clinic that I do. I actually go to every couple of years. I mean, I'm not advertising them, but I'm just suggesting that that's one way to learn about genetics. And then, of course, many courses that are available through this website through our colleagues. I mean, they've done a great job. So, I mean, these type of things you can do and learn more about it. But yeah, that's what basically happens. And a lot of times we just, we have to make sure, we have to tell them like, look, you cannot undergo genetic testing at this moment in time. Your family member who's affected needs to undergo genetic testing. And if they're positive and we know what they have, then we will do a genetic testing on you. Because you may end up getting like an erroneous genetic test result. You may get something that is common in the population, like a long QT. And then that could really screw up the diagnosis in everybody else in the family.
Thank you. And then we had a second question, and this was from Aisha, and she was saying, how often do you follow patients with negative genetic test results in your clinic?
So as mentioned earlier, I'm a heart failure cardiologist. So heart failure can be because of many different reasons. You know, there is a chunk of heart failure that's because of coronary diseases. There's a chunk of heart failure that's because of genetic disease. And then there is inflammatory conditions. And I guess I can take this opportunity to mention like at least one that is very common in Pakistani population too, but is under-recognized as sarcoidosis, which causes sudden cardiac death and cardiomyopathy, these that mimic a lot like genetic cardiomyopathy. So yes, I have a lot of patients in my clinic who do not necessarily, number one, do not have a genetic reason. Number two, who do not have a genetic test that's positive. So in those patients, I counsel them and I tell them like, look, the genetic test is negative, but you do have a very strong family history. And once that they have a strong family history, and we say that we could, you know, we'll keep you under surveillance, we'll see if something gets reclassified, or we offer them genome or exome sequencing. And I refer them all to genetic counseling. I mean, we have that service thankfully available to us, but I know in Pakistan, you can use this, you know, these guys, they've done such a great job in offering free tele-genetic counseling. So if you have patients, you can definitely refer them to this organization.
Got it. And then we have another question. This is Dr. Rizwan Naeem, and he's saying, what should a PCP or general cardiologist do if they encounter a family history of cardiac conditions?
I think that is the key. So what they should do is, if you're like a primary care physician and you're a general cardiologist and you're seeing somebody who has family history, one important thing is you can take a very detailed family history. You can take a very detailed history from the patients to identify if they have any symptoms of shortness of breath, arrhythmias, chest pain, something that would, or syncope, unexplained, you know, big one, symptoms. And you can ask them, you know, what, you know, details. I mean, I will say this, like, you know, everyone, we talk about a lot of syndromes, and Monisha gave a very like comprehensive overview, but to be honest, we don't necessarily like know, or like, you're not expected to know all these syndromes. What you need to understand is to kind of know how to, of course, everyone in medical school knows how to do a good history and family history, and then appropriately counsel the patient to at least, you know, get started, get an echo, get an ECG, get a monitor if need be, and go from there. So I'm going to stop here. I think the slides are.
Thank you. Thank you for addressing those questions, Dr. Kassi.
Awesome. Thank you so much for helping me out there. So my part of the presentation would be on familial hypercholesterolemia, and FH for short. I want to give a little brief backdrop of what's happening in Pakistan before I delve more into the science part of it. So there was a survey that was done recently with primary care providers in Sindh, in the province of Sindh, and in the province of Punjab. And collectively, they said that only about less than 10% of the individuals that they see that should be getting testing for cholesterol levels have access to a free cholesterol test. And this is just, you know, talking about your primary care providers and knowing that only about 10% of their patient population that requires the test has access to free test. We can already get an idea that the disease is going to be extremely underdiagnosed. And so whatever numbers we see, we could just think of it as, you know, drop in the ocean, because it's just an enormous disease burden, hypercholesterolemia in our community. And so with that, I'll take you on a trip with me to one of the patients that we saw at one of our telehealth clinics. So this patient we saw with is a kiddo, 7-year-old. We saw him in one of our telehealth clinics with his parents. And this is a 7-year-old Sindhi male. He presented with xanthomas on his arms and his legs. And these were his concentrations on the lipid panel. So you can see that he had LDL that was close to 600. There's VLDL that was also above the normal limits. HDL was borderline. And then you can see the triglycerides were also higher than the normal amounts. Serum cholesterol was also way higher than that normal amounts. With this kind of presentation, the doctors at the clinic were had already put the kiddo on ezetimibe as well as statins, and it was still not improving by a whole lot. So he was brought to the genetics clinic, and at the genetics clinic, when we did the testing, we looked for the four genes that are associated with familial hypercholesterolemia, and we were able to identify homozygous pathogenic variants in the LDLR gene. I'll go into a whole lot more details about this particular gene, what each of these terms means, but in brief, these are just the so the gene itself is called LDLR, which is LDL receptor gene. The variant means where in that gene the alteration took place. And so I'll be using the words variant and alterations interchangeably in lieu of using mutations, which is a word that we're trying to stay away from as much as possible. Zygosity tells us about how many alterations were identified. In this case, homozygous means both copies of the gene were altered. And then variant classification pathogenic, that means that the disease, this alteration is expected to cause disease. And then this is the family history that we took. So we have a clinic coordinator at each of these locations that we see patients at. And so the coordinators at those sites would take a detailed family history. So if I could walk you through this family history, you'd see that there's a consanguineous relationship, and the kiddo and our proband is one of 5 siblings. You can also see that 2 of his siblings had passed away of sudden death at the ages of 11 years old and at 9 years old. This patient has a sister who's alive and well at the age of 16, and another brother who's 2.5 years old who's also alive and well. You'd also notice that I've added a plus sign to the patient and to the sister, and that what that suggests is that that both of them had a genetic test that confirmed that the findings are suggestive of the disease. And so in this case, you'd see a dot inside the circle here for the sister, as well as for the parents and the 2 grandmothers. And what this indicates is that despite not having the genetic testing performed, these individuals, especially the parents and the 2 grandmothers, are considered obligate carriers. In other words, the kiddo who has 2 copies of the altered gene received 1 copy from each of the parents. And because the parents are in a consanguineous relationship, meaning that they have their mothers are sisters, the mothers are also then carrying the same genetic variant. They died, and from what I gathered, around in their 60s, and didn't have any signs and symptoms. But again, remember, these individuals did not have access to getting their cholesterol checked, so we don't know what their cholesterols may have been. And to the best of our knowledge, as of 2 days ago, these individuals, the parents themselves, have not had their cholesterols checked either. And so with that being said, I would now like to tell you a little bit about the signs and symptoms of familial hypercholesterolemia. So one of the, of course, the things that you would want to look at is the LDL cholesterol level. And if it's higher than 190 for adults and higher than 160 for children, whether or not there is a family history of early heart attacks or heart disease, if there is swelling or painfulness of the Achilles tendon, and if there are bumps around the knuckles, elbows, and knees. You'd also find that a lot of these kiddos would present with xanthomas, which are the fat deposits on the skin. And you can see this image on your right corner of the screen to kind of get an idea. You'd also sometimes see these xanthomas that are on the corners of the eye. And they become kind of obvious on presentation at time of the physical exam. One thing that we also notice sometimes is this arcus cornealis, which is the gray outer edge of the cornea. And this also may be pretty prominent in individuals that have higher levels of cholesterol. Now, talking a little bit about the natural history of the cardiovascular events, and what are the chances that somebody would have a cardiovascular event if they had familial hypercholesterolemia. So this is a really cool cartoon that tells us the little bit of the natural history of the disease. So essentially what would happen is that, to begin with, there would be a genetic alteration in the receptor gene for the LDLR. And if there is a genetic alteration in that gene, what would happen is that the LDLR protein would be malfunctioning and essentially will not be able to uptake the LDL that is present in the blood. And so you can see here that in the liver, there are these receptors, and these receptors are not getting to uptake the LDLR or the LDL into the liver. And what that would do is then it would cause elevated LDL cholesterol in the blood, and that can then result in hardening of the blood vessels called atherosclerosis. And that, of course, if it happens to be in the heart, it could cause myocardial infarctions and angina. So what is the chance that somebody who has a familial hypercholesterolemia would have a cardiac event? And we know that 30% of women who have this disease by the age of 60 will encounter a heart attack or have cardiovascular events. And excuse me. And in men, the number is a lot higher. By the age of 50, half of them, 50% of them, would have had a heart attack or heart disease. And finding and treating familial hypercholesterolemia early reduces the coronary heart disease risk by about 80%. So you can see how important it is to have early intervention in these individuals, and early diagnosis makes all the difference. This is a good representation of how often we see certain genetic alterations in these individuals and families. And so you'd see that the most common alteration is identified in the LDLR gene, the receptor gene I already talked about, and that's what I will be focusing on for the rest of the presentation as well. Whereas other genes are altered, like APOB, LDL, or AP1, and PCSK9. However, the numbers are rather small and they're rather rare. I also wanted to bring to your attention the fact that 40% of the time, even if there is clinical presentation and multiple family members with hypercholesterolemia, you might still not identify a genetic alteration when you order the genetic test. And then you can't go to a genetic webinar and not get a lecture on some of these genetics concepts. So I hope that you'd find this relevant and interesting, and also learn some new terminologies that you may not have heard before, because a lot of these are going to be talked about in literature and other things that you would see. So I just wanted to make sure that if I'm using some of these terms, that I'm explaining myself before I start to talk about them. So first of all, if you look at the cartoon on your right, you'd see that wild type or typical genetic presentation, you'd have 2 copies of the gene that do not have any alterations. And then the term heterozygous is quite often used when you have 1 copy of those 2 alleles that are not functioning or have an alteration that will cause disease. And so you call that heterozygous, but heterozygous can also be sorry about that. So yeah, heterozygous could also mean monoallelic, mono again meaning one, allelic meaning one of the two copies are altered. And we talk about homozygous, that's when two copies are altered, but both of the alterations are taking place at the same exact spot on the gene. And so we know that that can be called biallelic. Now, you'd also see this term called compound heterozygous in the literature. And what that means is that while there are two copies of the genes, the alteration takes place on different parts of the gene. And this could also be called biallelic again, because both of the alleles are not working. Now, next, I want to talk to you about the family history the genetics of familial hypercholesterolemia. First, let's start with the LDLRAP1 gene. This is the only gene out of the 4 genes that we mentioned that has an autosomal recessive pattern of inheritance. And what that looks like in a cartoon form is that if there are 2 parents, both of them having 1 copy of the gene that's altered, each of their children would have a 25% chance of having both of their copies altered, 50% chance that they would be just like their parents and they would be considered carriers of the disease and would not show signs of the disease. And then you'd have 25% chance that the children are, or that child is unaffected and is not a carrier, which we would call wild type or typical. I'd also like to show you this Punnett square, because a lot of us going through school drew a lot of these Punnett squares with big A, little a, big A, little a. So if you have big A, little a on the top and big A, little a on the side, you'd get 25% big A, 50% big A, little a, and 25% little a, little a. And then go on to the next group of genes. And so you have the most of our hypercholesterolemia genes are passed down through autosomal dominant pattern of inheritance. And those are the genes I already discussed a little bit earlier: LDLR, APOB, and PCSK9. And these are the genes that are associated with regulating and removing cholesterol from the blood. And so again, this is what a diagram would look like for autosomal dominant pattern of inheritance. You have 2 copies of the allele. 1 parent is affected because of that alteration. And then in their children, for each of the child, there would be a 50% chance of being affected, just like the affected parent, and 50% chance of being unaffected. And here's a little Punnett square again: big A, little a, and then little a, little a on the side. 50% chance of having a child with the disease, and 50% chance of having a child without the disease. Now, because I said we'll be talking a little bit more about LDLR, I'll be using that as an example. And you can see here in this cartoon that because our population in Pakistan can be more towards the consanguineous end of things, where cousin marriages are quite common in our population. This is something that a lot of you might encounter, where both parents are carrying at least one altered gene, or one copy of the altered gene, and then when they have children, you'd have about a 25% chance that each of their children would have both copies of the gene altered, the LDLR gene, and this will result in a more severe phenotype, as we saw in our case example. 25% chance that there would, 50% chance that there would be monoallelic alteration, just like the parents, and that would contribute towards a milder phenotype. And then you could have a 25% chance for each child to have no alterations and therefore would not have the disease. And then here's a Punnett square of the same. Next, I will go over the chances for the kiddo that has both copies of the gene altered, and what would happen if they were to have children, especially if they were having children with an unaffected individual. And in this case, you'd see that because the parent would be contributing, both copies would be altered. Each of their children would be at least carrier, and therefore will exhibit at least milder phenotype of the familial hypercholesterolemia. And then here is the Punnett score for that. The next slide that I have is kind of busy. It's a made up family history. And in this case, you can see that the darker individuals are going to represent the more severe phenotype, and the dash or the line individuals would represent more of a milder phenotype, again, based on their genotypes. But I also wanted to bring your attention to this person here, which is marked by this star. And what the reason why I wanted to bring that up is because sometimes you will see that there will be individuals who would be positive for a genetic alteration. For in this case, this person would be at least a monoallelic carrier, and there is a chance that they would not exhibit phenotype, because we know that 73% of the individuals with heterozygous LDLR alterations have an LDL-C greater than 130 milligrams per deciliter, and the rest, close to about 25% of the time, you will not see any phenotype at all. So that's also something that we would like to keep in mind. Now, looking at the differences between monoallelic and biallelic LDLR, we know that individuals that have monoallelic will show, at least as adults, will show over 190 milligrams per deciliter, whereas in biallelic, you'll see more than 500 milligrams per deciliter, especially if they're untreated. As far as coronary heart disease is concerned, there is an increased risk of premature CAD in monoallelic carriers as compared to biallelic carriers or biallelic individuals. It's a much severe presentation, and they could have heart or cardiac events as early as their mid-20s. In physical examination, you will find some individuals with monoallelic LDLR to have xanthomas that may develop over time, but like I showed you earlier in pictures, xanthomas, tendinous xanthomas, as well as interdigital, so between the fingers, you might find xanthomas in the children as well. As far as treatment is concerned, monoallelic carriers are usually treated with statins or lifestyle changes. However, in biallelic carriers, because there is so much disease present, that it is very difficult to treat them with statins alone, and they usually require LDL apheresis, which is the physical removal of the LDL cholesterol from their blood, and they're treated with additional meds as well. Now, this is a cartoon that I really like a lot. It's a very good representation of the severity of the disease in these individuals. So on your x-axis, you'd see the age of the individuals, and on the y-axis, you have the cumulative LDL-C. Let me walk you through this multicolor graph. So what you're looking at here, I'm going to start with the green graph on the bottom. So you'd see an individual who has no familial hypercholesterolemia. And as a typical adult, if this person would reach the level of 160 cumulative LDL-C by the age of 55. And that's when they are at increased risk for CHD, and that's the threshold which they reach at around age 55. Now, let me take you to the other end of this graph. Where you're looking at is a child who has homozygous familial hypercholesterolemia. And in this case, you'd see that this person reaches that threshold at 12 and a half years of age. And this, of course, is somebody who is not treated yet with any interventions. Compare that to somebody who's heterozygous or again monoallelic. This person without any intervention is represented by the red color here in the middle, and they reach that threshold by the age of 35. And then if the same individual is put on a high dose statin close to their 20s, they could see a difference of more than almost 13 years in the time that it would take for them to accumulate that much LDL-C, and they would reach that threshold at around 48 years of age. And then lastly, we're looking at if an individual who was put on a low dose statin, and they did start their intervention as early as 12 years of age, they would be almost so close to somebody who actually has no history and no familial hypercholesterolemia diagnosed. And so you can see that, the interventions early would make such a huge difference in these individuals with heterozygous familial hypercholesterolemia. Now, when it comes to homozygous familial hypercholesterolemia, this is much more severe disease, and a lot more intervention is required. And so we would, of course, suggest a lot of these things, and you're going to be seeing them in kiddos in their early teens, if not earlier than that, like we saw in our program, who was only 7 years of age. And then you're going to, of course, advise that they quit smoking, that they do physical exercise regularly, that they have a heart-healthy diet, and do weight management. And some of the modalities that you could use to diagnose them on top of their LDL-C are your echocardiogram, CT angiogram, and cardiac catheterization if needed. And here's a really good schema. If there are any cardiologists in the group that want to take a screenshot of this, you're more than welcome to do so. And this is, I got this reference from the European Atherosclerosis Society Consensus Panel. And this is the latest information that they have present, even though the paper was published in 2013, this is still relevant information for anyone who's interested. So essentially, if they're seeing a child and they have certain amount of LDL-C, they could of course start with the lifestyle changes and diet and statin. And if that isn't working, then perhaps go on to LDL apheresis. And if that is also not working, then perhaps refer them for a liver transplant. Yeah. And so I'll let you take a screenshot of this instead of going into any details about any of that. But my second to last slide is going to talk a little bit about why genetic counseling and genetic testing is important. We know that at least in our family alone, there were 12 living individuals that are currently at risk for disease that can be prevented. And especially in these parents, they have young children, they come from low socioeconomic strata of the Pakistani society. And so to provide them with any intervention would really be helpful for them and their families to live a long, productive life and have children that they could, they have children that they would need to be taken care of for some time. And so we've tried to talk to these parents, and we will continue to try to help them. But of course, there are barriers, and the PSMG and other groups are really trying to help avoid any major cardiac events in these individuals. And of course, the thing that we really need to be paying attention to is how do we prevent the disease from happening in any other family members, right? So one of the things that we would want to discuss with them is if there are any individuals on at least, this one side of the family. So for example, let's just say this father's sister was interested in marrying the mother's brother, which of course we know that happens a lot in our society, where two siblings marry a set of siblings sometimes. And so we would like them to know the chances that their future progeny or the future children might have, and how they could avoid that by doing pre-conception counseling, premarital counseling, and what interventions are available to them to help avoid that from happening in the future. And then one of the biggest resources that I think that is available to us, at least in the United States, is the Family Heart Foundation. They do some excellent work on, first of all, bringing individuals together to show them that your disease is not, you're not alone in your disease. There is a lot of help available to support these individuals in their journey. Of course, diet is so important, physical exercise is so important. And so if they can find a buddy or a partner, that really helps out a lot in their journey, and just not knowing that they're not in a silo, isolated from their disease. The other thing that such foundations and support groups can really help with is to help individuals understand, and even doctors and genetic counselors understand, how to communicate this information with at-risk family members that is age appropriate, culturally appropriate, and how could we do that in a manner that would be most helpful for the patients and the providers. For example, sometimes we like to write letters that we would give to the patient, and then the patient would take those to their family members or their doctors and show them that, I talked to a genetic counselor and this is what they had to say. And so the website at familyheart.org actually offers these templates. And of course, these templates are not in Urdu, but if a doctor on this call is interested, they can go and look at those templates, see what that looked like, and then PSMG can help them translate those into Urdu, and they can, provide that as a resource to their patients as well. This is a tremendous help. I've seen, so many times where patients are having such a hard time understanding this, but then also not knowing what are the right words to use. Like, how do I tell my uncle? How do I tell my aunt? How do I tell my cousin, brothers and sisters that this is something that they need to talk to their doctors about? That terminology just does not exist in Urdu just as frankly. And so, these resources would be super helpful. And then the other thing, again, is really helpful in these support groups is that they keep abreast with what's the latest clinical trial, what is the management guidelines, if there are any changes. And, this would be a great resource for anybody who's interested in keeping up with what's latest. So that is the end of my presentation, and I can stop sharing my screen now. I'm happy to take any questions that you guys might have. And of course, again, a huge thanks to PSMG.
Thank you, Aisha. That was an excellent presentation again. We had a few questions. Breen, who is one of our other genetic counselors, addressed some of them, but I will still read them to you in case you want to add something.
Sure.
The first one was Sumera Yamin. She said, great talk going on regarding the statistics shared for genes, primarily LDLR. Is it coming from South Asian data or white data? Wouldn't this be a question of ethnicity?
Yeah, no, absolutely. That is the numbers that I provided. So we get this from pretty much all papers across ethnicities, that 1 in 500 individuals would be carriers of LDLR and other FH genes. However, you're absolutely right. That number is probably way underestimated for the Pakistani population because we have not done a thorough investigation. However, because the number 1 in 500 is seen across multiple ethnicities, it is possible that that number is going to be similar for our population.
Okay, thanks, Aisha. And then I see that. Okay, she had a follow-up question, which was for Aisha. My understanding for recessive traits is that the other copy of the allele is partially protective, and that's why it's a mild phenotype.
That's correct.
Okay, and then I see that we have, hang on one second. Sorry about that, my window got closed. But I see that we have Dr. Azam Shafkat in the audience. Is he still there? So Dr. Shafkat, he's a professor at NICVD, and he's a professor of cardiac electrophysiology. And if he is still there.
Yeah, I see him.
Okay, perfect. And without me putting him on the spot, which I kind of am, but if he is able to, if he could just, make a few comments maybe about just being a cardiologist in Pakistan and cardiogenetics and what just his experience, that would be great. If not, that's okay too, but.
That's all right. That's all right. Thank you for the presentations. I'm sorry I could not be part of it from the beginning. I had another commitment, so I joined a little late. I think this was a wonderful, all the presentations were wonderful. Regarding the current status of things, I'm not sure what the rest of the participants are. I believe, from what I could see, we have some people who are medical genetic counselors, I believe, and I'm sure there are some people from Karachi and other places in Pakistan. So our current status is, I can tell you what's going on at NICBD, which is in Karachi, is that we do see a fair number of genetic arrhythmias. We have been doing some genetic testings, but they are limited in terms of how we can provide our patients with access. We are looking to establish a genetics clinic for arrhythmias. We had a very, very useful conversation with Dr. Rizwan and Aisha. I think our way forward is going to be to try and find someone who we can have trained in counseling as it should be. We have some groundwork to do on our part, and hopefully we'll be proceeding with that soon. It's basically to create a position in a government institution takes a little bit of doing. I think that's pretty much all I have to say right now. So I think maybe on another occasion we could have a little bit more background available, and I could provide you some more data. We have, I think I will stop there. I'm sort of dragging on. I apologize for that.
No, thank you. It was very good to hear, because while we're all sitting in the US and giving our perspectives, really we need to hear the perspective from the people who are in Karachi. So thank you for sharing. And I think there's one more question, and maybe that'll be the last question, and then we will just wrap it up. But okay, so one more question, which might not be relevant for FH only, but maybe worthwhile to know numbers. So for these disorders which appear not really polygenic in nature, I assume there is whole genome sequence going on. Is there any effort going on to build a reference panel for the Pakistani population?
Yeah, that's a good question too. So is that from Samara? Yeah. So Samara, there is a reference genomic, what's the word I'm trying to find here? There is a reference genome for the Pakistani population. It is a combination of Indians and from the Gujarat area, as well as Pakistanis from the Lahore area. That is part of the Genome-Wide Association larger consortium. And if you go to Genome AD, you would find that reference exists and is being used quite often. And we are seeing more and more of these variants that are being identified that are only in the South Asian population. And so there is quite a bit of extensive work that has already been done. And there's of course, never ending. This is never ending, and it's always going to be improving, but that reference already exists.
Thank you, Aisha. And I think with that, we're going to close out the session. I just want to thank Dr. Kassi, Monisha, and Aisha.
One more question that I just saw in the corner of my eyes, and it is from SY. Is that Samara again? I think it is. And if you don't mind, might as well.
Mm-hmm.
So she says something along the lines of a certificate for genetic counselors online. And I'm sorry if I didn't figure out who it was, but basically the answer to that question is that in Pakistan, there is no online course that is available yet. The Pakistani Society of Medical Genetics, and if you remember looking at our mission statements, one of the biggest goals of this organization is to develop a program. And one of the reasons why we do these lectures is because we're trying to accumulate enough wealth of information where we can provide it in a form of a course. And so hopefully, inshallah, in the near future, we will have something available. Now, having said that about Pakistan, if there are individuals in the call who have the resources to maybe connect with somebody in United States, there is, at least from what I know, and please other panelists, if you guys know this, please share, there is at least UCSD, which is the University of California, San Diego program that offers a pre-genetic counseling course that you may want to look into. It's a short course and it is available. Of course, you know, it's on the expensive end and may not be available to everybody. And it's not a genetic counseling course. It's a pre-genetic counseling short course that a lot of students like to take if they can, to see if they can get a leg up on applying when they apply for genetic counseling programs. Besides that, there are a couple of programs in the United States that offer online master's program in genetic counseling. And of course, you still have to apply as per usual. You still have to take all your entrance exams, whatever their requirements are, fulfill all of those. And then maybe some of them would require you to travel to the United States and get your visas for the rotations and the clinical training. So that all of that is available, but we're really trying to do as much as we can to bring it to Pakistan, and please help support us as much as you can, because we can't do it without your help.
Thank you, Aisha. Very good information. So with that, I am going to close the session. I want to thank Dr. Kassi and Monisha and Aisha for the excellent informative presentations. This webinar is recorded and will be uploaded on psmg.org, which is our website. On there, you can also find all of our previous webinars that we have done. So there's a whole bunch of talks there. If you're interested in any of those topics, please take a look. They're recordings. Thank you for your undivided attention. Thank you for all the questions and the great discussion. And reach out to us if you have any comments or other questions.
Bye. Thanks, Myla.
Bye.
Thank you, everyone.